Today we're going to discuss heavy menstrual bleeding. Thank you Caliph84 for requesting this video. NICE defines heavy menstrual loss as excessive blood loss that interferes with a woman's physical, social, emotional, and/or quality of life. Menorrhagia is a very common presentation in general practice. The average menstrual cycle has a blood loss for 7 days of a cycle between 21 and 35 days. Excessive menstrual blood loss is classified as 80 mils or more and/or duration of more than 7 days. In practice, a direct measurement of blood loss is complex to obtain. The psychosocial impact of heavy menstrual bleeding should be explored because it can be debilitating for women who have heavy bleeding and flooding, as this can get in the way of the daily activities. Let's jump right into our case. Your next patient is Mrs. Jones, age 30. She would like to speak to a GP about her heavy period. What would you like to ask Mrs. Jones? In data gathering, it's important to let the patient tell you their story from the beginning. How did the heavy period first start? Ask about the nature of the bleeding, duration of blood loss, and the impact on the woman's quality of life. Inquire about first year of menarche, history of menstrual cycle, what's the length of the cycle. Ask whether the patient is up to date with her cervical screening. When was the last time she had a screening? Was it normal? Asking about sexual history is important in this presenting complaint. Ask whether the patient is using any contraception. Hormonal contraceptives may cause irregular bleeding. Ask about contraceptive plans and future plans for a family, as this may impact on the choice of treatment. Consider the possibility of pregnancy, including an ectopic pregnancy. In all women with menorrhagia, it's important to think about pregnancy. Menorrhagia may present with related symptoms such as persistent intermenstrual bleeding, pelvic pain, or pressure symptoms. Checking for the presence of red flags is vital to make a safe assessment. We've talked about intermenstrual bleeding, also about postcoital bleeding or any dyspareunia. It's important that you signpost your question before asking such sensitive questions. Ask about any symptoms to suggest anemia. If a woman is losing a lot of blood, then there's a risk of anemia. In the patient's past medical history, ask about any clotting disorders, what is a thyroid status, and ask about gynecological history. It is vital to explore patients' health agenda. Asking about idea, concern, and expectation will help you to understand patients' perspective. Make sure that you don't come across formulaic when you're asking idea, concern, and expectation. You might want to say to Mrs. Jones, "Have you had any thoughts? Was there anything that you were worried about? What were you hoping I could do to help today?" Explore psychosocial elements of the case. Heavy menstrual bleeding may have heavy impact on the patient's home and work life. Explore how the symptom is affecting the person's life. This will help you to understand the severity of the illness. Let's say Mrs. Jones tells you that she has experienced bleeding between her period and pelvic pain. What would you recommend her? If a woman has a history of heavy menstrual bleeding with related symptoms, consider offering physical examination. It is vital to explain what examination you propose to perform and justify the reason for doing so. It is recommended to offer a chaperone for intimate examination. You might want to perform an abdominal examination to assess for large fibroids or other masses. You might want to consider bimanual examination and speculum to assess for ascites, fibroid, or gynecological cancer. Visualizing the cervix might give you an idea whether it's healthy or not. Once you have taken a focused history and discussed examination, the next step would be to think about investigations you might want to consider. Investigations include simple blood tests to check full blood count for anemia, for suspected submucosal fibroids, polyps, or endometrial pathology. NICE CKS recommend that we offer referral for outpatient hysteroscopy to women with menorrhagia if the history suggests submucosal fibroids, polyps, or endometrial pathology because they have symptoms such as persistent intermenstrual bleeding or risk factors for endometrial pathology. If you suspect possible larger fibroids, offer a pelvic ultrasound. If you suspect adenomyosis, offer a transvaginal ultrasound. If the woman's history or examination suggests a low risk of fibroid, uterine cavity, abnormality, histological abnormality, or adenomyosis, consider starting pharmacological treatment for menorrhagia without investigating the cause. If you find abnormalities on a physical examination, such as ascites or pelvic or abdominal mass, which is obviously due to uterine fibroids, urgent referral is warranted. If the woman has a pelvic mass associated with any other features of cancer, such as unexplained bleeding or weight loss, a suspected cancer pathway referral within 2 weeks should be arranged. If there are complications such as compressive symptoms from large fibroids, referrals should be arranged as well. If the woman has iron deficiency anemia and has failed to respond to treatment and other causes have been excluded, a referral should be arranged. Let's say Mrs. Jones does not have any related symptoms apart from heavy menstrual bleeding. You'd like to discuss pharmacological treatment with her. What would be your first recommendation? LNG-IUS, also known as Mirena, is a first-line treatment for heavy menstrual bleeding. This is a long-term treatment and should be left in situ for at least 12 months. This would be suitable for a woman who is not planning to become pregnant. Second-line treatment includes tranexamic acid, non-steroidal anti-inflammatory drugs, NSAIDs such as mefenamic acid, or the combined oral contraceptive. It's important to consider the risk of tranexamic acid and non-steroidal anti-inflammatory drugs and explain to the patient the benefits and the side effects. If you're considering starting a woman on combined oral contraceptive, make sure that you check the risk factors, for example, breast cancer, DVT or P, and also about their smoking status. Make sure that you check the woman's blood pressure measurement and BMI. The UKMA classification is a useful tool to help you in starting a patient on contraception. Third line treatment is with progestogen, either norestesterone 5 mg 3 times a day from day 5 to 26, or injected long-acting progestogen such as medroxyprogesterone acetate, also known as Depo-Provera, every 12 weeks. Non-pharmacological options include endometrial ablation, uterine artery embolization or hysteroscopic myomectomy, and lastly, hysterectomy is a radical treatment if nothing else has worked. I hope you find this video useful. Make sure that you subscribe to this channel if you've not already subscribed. Let me know down in the comment section if you have any suggestion or any thoughts about this scenario. If you're preparing for the LCA, I've got a video I want you to watch. This is a video where I sit down with Dr. Nigel G. and we talk about the strategies, tactics, how you can get your cases for the LCA. As always, make sure that you subscribe if you're not already subscribed and turn on notification bell. Take care everybody. Bye bye.